Hello and welcome to our case study review related to asthma, where we're going to be going over a case that was provided, and in so doing, trying to see if we can find certain aspects of the history that are suggestive of asthma, and also highlight if there are any triggers of note. And keep in mind that in the lecture we also had a classification system that we're going to try to incorporate into this case to have a better sense of the severity and frequency of the presented condition. So to begin, let's review over the case history. We have our patient, a 25-year-old, previously well woman who presents to her doctor with complaints of episodic shortness of breath and chest tightness. She has had the symptoms on and off for about 2 years, but states that they have worsened lately, occurring 2 or 3 times a month. She notes that the symptoms are worse during the spring months, and she has no exercise-induced or nocturnal symptoms. Other things of relevance related to the case history. The family history is notable for a father with asthma. She's single and works as a secretary in a high-tech firm. She lives with her roommate, who moved in approximately 2 months ago. The roommate has a cat. The patient smokes occasionally when out with friends, drinks socially, and has no history of drug use. An examination is notable for mild and expiratory wheezing. The history and physical examination are consistent with a diagnosis of asthma. Now, when you're completing a clinical evaluation of a patient, you don't just complete objective testing. You have to complete a subjective assessment. You want to complete an interview with the patient. So in the previous 2 slides, we have a couple of paragraphs that we've broken up a little bit. But if we just focus on those paragraphs, we might miss some of the relevant points. That's why clinicians, when we're involved in doing a subjective assessment, we will utilize a structure that will break things up bit by bit so that you can better isolate if there's relevant aspects to each section. So by breaking it down into these different categories provided in the case, it's in the hope of better appreciating what might be there that would be affiliated with asthma and give us a better sense in terms of triggers that might be present, as well as the intensity and frequency that could be there. If you talk to a patient long enough, they'll tell you what's wrong. If you talk to them a little bit longer, they'll tell you how to fix it. If you can take that information and categorize it effectively, you're much more efficient in taking that next step in terms of what objective assessment you should perform and what interventions might be best going into the future. A friendly reminder related to the asthma classification that we went over in the lecture. There's mild intermittent, mild persistent, moderate persistent, and severe persistent. We have, arguably, from step 1 to step 4, a progression of 2 concepts of frequency and severity. So I've taken the categories that were highlighted on 2 slides ago, broken up the 2 paragraphs, and took the information from those paragraphs into these different categories. So if you could, pause the presentation right now and see how what you marked down related to these aspects matches up to what we have here on the screen. Okay, welcome back. Notice at the top it says case findings that might be suggestive of asthma. Not everything that you have here on the screen is relevant to answering that question. Some things that you pick up during a subjective assessment are just points of interest, or it might be something that will come on later on, or things that you want to make sure you're aware of. Health status previously well. It's not suggestive of asthma, but it may be suggestive of timeline. So what might be more relevant in terms of asthma? Well, shortness of breath, chest tightness, worsening lately, approximately 2 or 3 times a month. Further in the past history of current condition, on and off for about 2 years. A family history, notable for a father with asthma. Now, this does not relate back to the frequency or severity, but we know that genetics may play a cause in the development of asthma. Also, mild and expiratory wheezing. It is a finding that may correlate also with asthma, so that where we do an auscultation, we can notice that yes, there's end expiratory wheezing that's present. So if we look at each of these points, they are maybe a suggestion of asthma. If we look at all of them together, that's telling more of a story that, yeah, this could be an asthmatic presentation. But when we talk about that, we want to also consider provocative factors or triggers that might be present. So with a dashed line, let's highlight a few other things that could be relevant. We know that the symptoms are worse during spring months. So during the spring, we have pollen. We have other triggers that might be present. Even people who initiate spring cleaning, there's going to be some dust in the air. And there's no exercise-induced or nocturnal symptoms. So while it's relevant for us to be aware of what are some of the triggering factors, it's also relevant to be aware of some things that are not involved. Something else that is involved, though, the living environment. A roommate who moved in about 2 months ago, and the roommate has a cat. And cat dander or pet dander can also be triggers related to asthma. So at this point in time, there's enough here where we suspect the presentation of asthma. But is there anything here that gives us a suggestion related to the severity? Well, if we're looking at the occurrence of 2 or just 3 times per month, that's barely putting it into step 1. This would be a mild, intermittent presentation at this time. 2 times per week at most. Now, the treating clinician may, upon review of the history, say, okay, let's consider some of the triggers and see if there's a way you can avoid the triggers. How effectively is the roommate cleaning up after the cat? Is there enough vacuuming that's going on inside the house? Do you need to open the windows? Is there other factors here that we have to be aware of? There might be a little bit other things that we want to try to tease into. Occasionally smoking, you might want to pair out what occasional means. Again, could be a trigger. Other ways of just trying to, follow up related to self-management. How often does the patient get outside? How often does it influence her symptoms there? What time of year are we talking about? It wasn't mentioned in the case. Is it spring right now? Or is it, as we are right now, going into December? So, depending on the time of year, that may influence what's going on with other triggers. But at least at this stage, it is mild intermittent. The patient may not require any medication intervention at this point in time. It could be just a matter of monitoring, but also self-awareness on the part of the patient. And the clinician can provide that education to redirect and change aspects of the day to mitigate and correct some of these symptoms. But also, the clinician's responsibility is to monitor the patient. So the patient will probably need to follow up again 2, 3 months down the road to see how that management is going. If it's effective, perfect, keep going. If it's not, well, then the discussion has to be had about, is there a way to further address triggers, or is there the need of medical intervention?